Good afternoon, everyone. I thank you for that gracious introduction, Karen. I want to say thank you to our friends at Mental Health America and to Schroeder and her entire talented team here for hosting this conversation today, for providing thought leadership and targeted advocacy. And as we're going to talk about it here today, I'll say specifically to strengthening Medicaid and CHIP, those benefits that are so critical to our stakeholders. Without further ado, I'd like to introduce Dr. Jessica Lee from the Centers for Medicare and Medicaid Services, in particular the Center for Medicaid and CHIP. She leads the center's clinical strategy as their chief medical officer. She's also been the chief medical officer at the Division of Quality and Health Outcomes at CMCS. She's very well, I think, positioned to be discussing today's topics with her expertise in clinical medicine and quality, and her particular focus, including a job she had at the Government Accountability Office looking at payment policy and research focused on the intersection of health care delivery systems and population research. So really perfectly poised for the conversation we're going to have. I know this is a total setup for you.
Thank you.
But speaking of thank you, before we go on and start having the conversation, as the representative in the room of the Biden-Harris administration, although I know there are a couple of others here, I don't want to fail to acknowledge you. I know you'll be introduced later, but especially on the healthcare side, I think all of us who care about ending disparities, ending discrimination that affects people who are at risk for or live with behavioral health conditions, we're so grateful for the new parity rule. And for people who haven't had a chance to read it and who love regulation and law, do go read that new final rule that was issued last week. But it will require health plans to be more transparent about things like out-of-pocket expenses that patients encounter, about types and rates of denials, and other things, that the rates that are paid to providers. So, and the time and distance to get back and forth to appointments, which I'm reminded of by those people talking about rural counties in Virginia, for example. So anyway, as a bit of background that Karen Howard was generous in providing us, mental health associations across this country are some of the strongest advocates for reforms in insurance and in benefits that will make the lives of people who, as I said earlier, are either at risk for or living with behavioral health conditions, whether that is the state affiliates or at the national level. And Medicaid is so critical, Medicaid and CHIP, the opportunity to integrate care at the earliest stages of a child's life, and well-child visits in primary care, for example, and even for older adults who might have emerging behavioral health conditions, couldn't be more important, as well as those benefits that are focused on people with disabilities and complex health conditions. So I know some of our mental health affiliates, MHA affiliates, are actually engaged in providing services and billing Medicaid. So I know you'll be very interested to hear about this. And many of the affiliates are involved in providing or supporting peer services that are increasingly able to rely on reimbursement. So may I start with my first question for you?
Yes, please.
Okay. So as much as I love parity, I would love to talk about this new bill. It's a new policy that you put out, and really the advisory that came from the federal government back in November of 2023, but it's about coverage of health-related social needs and those services that would support that. So I'm wondering if you could talk a bit about that bulletin that was issued back in 2023, which really provided a framework to the states for beginning to explore how they could cover those services and provide a more robust response to the complex needs of their Medicaid-covered lives. So if you don't mind.
Absolutely.
Thanks.
So first, thank you for the parody shout out. We have been really excited about the whole package of work that's really been coming out, not just here, but also additional work that additional guidance and support that we provide to states to implement parity. So really, a whole suite of guidance that we've been very excited to issue, and are also really grateful to all of you, many of you who I think provided us with comments, which were so valuable in terms of making this guidance as helpful as it could be. So turning to health-related social needs, this is a term that it's a bit of a term of art. So just to start with some level setting with language, we think of health-related social needs as the individual level experience of the broader social determinants of health at a community level. So that's kind of how we've been defining things. So thinking about this, what really prompted us to issue the guidance in November is two things. First of all, just the enormous body of literature that supports the profound influence of health-related social needs on an individual's health. Just enormous body, irrefutable evidence in terms of the ways that you can support individuals in a variety of ways that sometimes we were doing and sometimes we weren't. And then the second thing is state partnership, that many of our state partners were interested in trying new innovation, and were looking to us to work with them to figure out how to do that in Medicaid and in the Children's Health Insurance Program, or CHIP. So in that guidance, we put together a few different things. The first is that we compiled there things that we've been allowing under Medicaid 1115 demonstrations, which are experimental or pilot demonstrations that states can apply to us to do. And so we put together services and interventions that we consider allowable there. But we went beyond that, and we also put together services that we consider allowable under other authorities, specifically under managed care flexibilities. They're available in any state with managed care programs, which is the vast majority of the country. Under home and community-based services, which has been an incredible and critical foundation for the provision of these services overall, and under the specific program in the Children's Health Insurance Program. I'm highlighting this because a lot of times the 1115 demonstrations get the headlines, but the beauty of all of these services is that you don't have to do an 1115 demonstration, which can be, challenging for some states, both in terms of the amount of workforce time it takes and also the political climate. You don't have to do that to do this. There are so many different authorities, and actually almost every state in the country, if not every state, are using one of these authorities to address health-related social needs. For example, more than 43 states are using the Home and Community-Based Services Authority to address something related to housing. And so it really is trying to make all of these opportunities as easily accessible as possible in every state in the nation to try to complete this picture of whole person care that has had more and more evidence to support it in the recent years.
That's great. Can you hear me now? Sorry. That's great. Have you seen you mentioned some of the states using the authorities to focus on housing. Are there other areas in terms of social needs that you might call out where you've seen interesting demonstrations that might give the audience some ideas about how to go back to their own states and suggest drilling down and using this new opportunity?
Yeah, so I would say to start that so many states are considering these demonstrations. So in your state, keep an eye out for whether or not your state's proposing this, because you'll have an opportunity through public comment to make suggestions about services, about populations to serve, about clinical conditions that you think are important. So these are things to kind of keep an eye out for. But beyond that, there are other things that your state can do. There are things that your state can do, as I was saying, through these other services. When we think about the 1115 demonstrations, we've authorized services in two categories: nutrition supports and housing supports. There's additional services that are available to beneficiaries, though, that are important to highlight, because this is by no means the end of health-related social needs. It's just an area of focus where we're trying to make it very clear to states what they can expect us to approve. Other additional areas include transportation. In Medicaid, there's a really special treatment for transportation. There's actually there's a transportation assurance that's required by states. That's important to know about, by the way, because it actually includes things that you might not intuitively know it includes, like opportunities for transportation for caregivers, and also things related to for example, if you have a child who's getting care out in a different state. You can actually look at the transportation guide we issued last fall for a lot of these examples. So, it's not, while we highlight nutrition and housing supports and the guidance we've been releasing lately, we recognize that it's really about whatever the beneficiary needs to sustain their health. And I think that's, how we've been thinking about this policy as a whole, is we're trying to create policies so that, when a provider is in the room with somebody, they're able to give them what they need to sustain their health, and able to kind of complete that care plan with whatever additional services are needed that are related to their health.
Thank you very much. I'm going to mention one other that I heard about just because a number of Mental Health America affiliates have long been in the business of having information and referral lines, resource databases for people to access peer support and warm lines. And North Carolina is exploring the use of this benefit for something called NC360, which is digital referral network that they've created. So it's I think been part of this Healthy Opportunities pilot that they're doing. But Karen Howard had mentioned it to me, and I wanted to share that with folks. It's also designed in their case to reduce the use of emergency rooms and to help with diversion to other services. So if I could switch topics, there's another very interesting, because you mentioned housing, very interesting initiative called the Housing and Services Partnership Accelerator, HSPA. That's one of those things, if you can say it like 3 times quickly, you're pretty facile. Anyway, the Housing and Services Partnership Accelerator is a new opportunity for states. It's got an approved, any state that has an 1115 demonstration or an approved Section 1915I waiver. I come from a state that loves waivers. I know not every state does, but I think many of you might have these. These benefits, or these state plan benefits, can cover housing-related supports and services, particularly focused on the population of people we advocate for. And they're designed to strengthen the state Medicaid agency's collaboration with housers, with people providing other aging and disability-related services, which are so critical to ensuring that people can live stably in their communities, not be at risk for or end up in institutional settings, keeping states on the right side of the Olmstead decision, for example. So I was wondering if you could talk a little bit about how HSPSA is helpful with respect to supported housing development, the research around supported housing, if you might.
Yeah, absolutely. So I'm not going to steal the thunder completely from the people who are coming after me in this.
We're the warm-up act.
We're the warm-up act. But I want to think about this learning collaborative in kind of a broader sense. The learning collaborative is intended for state Medicaid programs with programming oriented towards individuals who are experiencing homelessness to come together with their housing partners and basically work it out, figure out how to actually implement this policy into the nitty-gritty things, like how to actually bill for services, how to do these referral patterns, different ways to get providers credentials, get into that with supported technical assistance from both HHS and also HUD. So we all come to the table together. It's included both online sessions, one-on-one technical assistance, in addition to an all 2-day in-person session with states. I have to say, seeing people in the hotel at 10 p.m. talking about this is really, there's nothing more inspiring than when you actually see people doing that. And so, the Learning Collaborative has been so important, because if you can, I think everyone in this room can actually imagine how difficult it is to operationalize something this new. And for us, we are not a housing agency. And so states come to us with questions that we've never gotten before. And actually, when we ask around, many times they haven't been asked before. And so these are new questions, new issues that they not only need a resource to turn to, but frankly, we do too. We need a partnership with our fellow agencies. And I think that's really one of the critical aspects about the health-related social needs framework and the whole policy, is that it really is about partnership, because this cannot work without partnership at every single level. At the federal level, it's partnerships with our colleagues, for example, at HUD and at USDA, to make sure that our benefits are not duplicating theirs. We're here to complement the existing housing and social service infrastructure. You'll see that, for example, in the 1115 demonstrations that do cover this, because one of the requirements is that states have to maintain expenditures for the related housing and social services or increase them with the 1115 demonstration, highlighting that we're not replacing the existing infrastructure. We're here to help. We're here to complement and provide the additional services that someone might need for their health. So, that partnership is at the federal level, but it extends every single level in order to actually make this work, both between us and our state partners, but also between state partners and both providers and community-based organizations that are absolutely critical to providing these services, whether it's there are other housing programs at a state level, or if it's the individual providers who have to be part of these referral networks, or who have to learn how to be reimbursed by Medicaid for the first time. As a provider myself, that's not a simple thing. So, coming together and providing a place for states to work together with both each other and their housing partners and build those collaborations, like both vertically and horizontally, in terms of the system, has been just critical in getting this off the ground.
Thank you. The people that we have long worked with, represented, been friends of, family of, been ourselves, who live with mental health and substance use conditions, are most at risk of homelessness among other vulnerable groups. And among people who are chronically homeless, they are overrepresented. And I think anytime there's been a conversation, certainly many I've been part of, I know others here have been part of, about solving that problem, solving chronic homelessness, preventing homelessness, targeted to better meeting the needs of people who live with those conditions. Inevitably, the topic of the affordability of housing comes up. I'm wondering how that notion is in the mix here.
That is such a great question, because at the end of the day, if that's really a critical part of actually being able to transition people to permanent supportive housing, is the ability to find that. And I think that's where we've really emphasized how important the partnership is between state Medicaid programs and their housing partners, in order to kind of identify that, and also to inform policy, about what the local needs are, what beneficiaries are experiencing, what gaps in care they have that are related to housing. So I think that partnership is really critical in terms of being able to look at the full landscape and figure out what a community needs.
Another topic we wanted to ask you about is about case management, and how it's, as many people here know, somewhat different from peer support, in that it may include assessment and other services depending on what a particular state's requirements might be. Often involves linkage to non-clinical services, as well as trying to help people get better access to clinical services. I wondered if you might discuss how the states are using non-clinical peer support services to complement clinical services and address the social determinants of mental health.
Absolutely. I wouldn't even necessarily think about this as social determinants oriented, and really more just about health oriented, about what kinds of services you need to support an individual. And the peer support aspect is so important. We've issued guidance really recently in the form of an FAQ document, trying to make sure that states are aware of all the flexibilities they have to provide peer support services, in addition to flexibilities around provider qualifications and the supervisor role. And so you can take a look at that guidance, but it also includes, there are several states that are providing peer services in the school environment, harkening back to the presentation just before us. So really highlighting the range of opportunities, because again, it all comes down to what an individual needs, and trying to make sure that when you're trying to implement an individual's care plan, there aren't gaps in that care plan that could best be filled by something that's not covered yet.
Thank you so much. Is there anything else you want to comment on?
Yeah, I think, one thing you mentioned before is about the overrepresentation of individuals with mental health conditions and substance use disorders among those who are experiencing homelessness. These are not simple solutions, but I think one thing that we've tried to emphasize is the resources in Medicaid and CHIP to both provide behavioral health services and to support housing needs. Noting that these are two different parts that can, for some individuals, be inextricably linked, for sure, but that these are services that are available, that both housing-related services are available in addition to services to support mental health conditions and substance use disorders in a variety of ways. And so that full range of services is something we've really tried to highlight, including in some guidance that we issued earlier this spring, specifically on this topic. Again, trying to create a situation where we have a person-centered care plan that can be enacted using the Medicaid and CHIP-covered services.
Thank you. And it's time now to see if people would have some questions they'd like to ask.
So I'm from Kentucky, and we just recently got permission to treat folks in our prison system for substance use and some mental health conditions with Medicaid dollars. I'm wondering, is there any talk about doing that in juvenile justice with using CHIP and Medicaid dollars? Is that somewhere that we're talking about expanding, or is that somewhere we need to start the conversation?
That is somewhere where we need to continue the conversation. Thank you so much for answering that. So there were juvenile justice-related requirements passed by Congress just this last year, and we put out guidance to states just recently implementing them. And so I'm happy to send those along. But this highlights, again, kind of across the lifespan that we're trying to provide more opportunities at continuity and at making the connections that are needed to make someone successful in living in the place that they're choosing.
Hi, Naomi Fenner, Director of Population Health at Families USA. I actually came from Massachusetts Mass Health, where we did a lot of waivers.
Nice to see you here.
Nice to see you too. Kate Guinness says hi. Wondering, now that we're in DC, one of the things that we're hearing from states is that there's a lot of backlog of these 1115 waivers. And a lot of these states want to implement these services, and we've kind of gotten to a point where the demonstrations are working. We know that housing is really improving health and reducing costs. Same with nutrition. Has there been any talk of kind of streamlining the process for states that are in the queue, especially given we have an election coming up and potentially a new administration with a different tact?
The short answer is yes. And you'll see some of the streamlining that we're doing in as was just mentioned, the reentry demonstration. So you'll see that we approved a bundle of demonstrations at the same time. And so we are doing a lot of different processes right now to try to streamline. This really reflects that, and this is a good thing, that the number of states that have wanted to do innovative and new things has just gone up and up and up. If you look at our numbers, they have not. So we are working with that demand as quickly as possible. It is ending up being a balance between trying to streamline by providing templates, for example, and infrastructure like the framework where you can copy paste things, right? And so trying to make things as streamlined for states as possible, with the fact that states often come to us because they want to do something really specific or really different. And so those conversations are part of the balance, the fact that we want to work with our state partners to do creative new things while also trying to get through our backlog as much as possible.
Others?
Are there any conversations across the federal government? Are you working with HUD? I know a lot of housing funding kind of circumvents the state level that houses, state has control over Medicaid, but then can sometimes get skipped by critical housing programs that falls a lot in local control. So are you guys doing any work with HUD to evaluate how their programs are running, any sort of cross collaboration at the federal level if we're trying to model at the state level?
That's such a great question. The short answer, again, is yes. We collaborate with HUD. I'm just going to say to the point where when I start to type a name into my email, Richard, the first one is Richard Cho from HUD, and my father's name is Richard. So, yeah. We collaborate with HUD a lot, both to think about the different ways to integrate opportunities, and even some of the basic things like how to integrate data systems, which is so absolutely essential. And I think I like the way that you are talking about trying to have a federal partnership that the same thing at the federal level that we're asking our states and local and community partners to do, because we really are trying to do that. I think some new policy that HUD's put out related to a specific set of vouchers is actually a great example of that, and I'm sure that Richard's going to talk more about that. And so like that kind of policy where the partnership between the different areas that are historically siloed, you really see the link between the different policies, and we're excited about it.
I think we have time for another question.
It looks like a question came in online.
Great.
Desha Baker asked, would you be able to provide links to the CHIP recommendations mentioned? And I think that might be the juvenile justice?
I think there might be two things. It could be the CHIP health service initiatives, and I can definitely provide guidance about that. That's one of the columns in our framework, and it's a specific policy opportunity under the Children's Health Insurance Program that all states can implement. And then the other might be related to juvenile justice, and I'll also provide those links.
Thank you so much. We really appreciate you taking the time to join us, and if there aren't any other questions, we will go to a break. All right.
Thank you all so much.